Hello and welcome to my channel. In this channel, we explain various nursing concepts in a simple form for a better and easy understanding. These videos could be used by both LPN and RN students as well as nurses who are trying to refresh their basic concepts. My name is Nasmosh. So in this video, we're going to talk about shock and valvular disorders. So shock. What is shock? Shock, it is an inadequate delivery of oxygen and nutrients to support vital organs and cellular function, resulting in impaired tissue perfusion. Shock is not an acute condition. Remember that. So there are various types of shock. There is cardiogenic, hypovolemic, and distributive shock. So what is a cardiogenic shock? A cardiogenic shock is failure for the heart to pump adequately. It's like due to a heart muscle injury. And some of these injuries include an MI or a cardiac arrest. Hypovolemic shock, volume. It's a decreased circulatory issue. So a decreased circulating blood volume, either from bleeding, right? Low volume or dehydration. Or even a burn patient could have a hypovolemic shock. Distributive, which is a circulatory issue as well. And with distributive, there is three types of distributive shocks. So with distributive, there is vasodilation that causes blood to pull into the peripheral vessels. They include a neurogenic shock. So with the neurogenic shock, which is under distributive, it's caused by spinal injury and certain medication or hypoglycemia. Signs and symptoms of this include warm, dry skin and bradycardia. So with spinal injury, certain medication or hypoglycemia, there's that fluid shift, distributive issues. There is anaphylactic shock. With anaphylactic shock is hypersensitivity to reaction that causes a sudden onset of hypertension. It's life-threatening. They may also experience a respiratory distress as well as cardiac arrest. So when somebody is going through an anaphylactic shock, immediate response is required, please. Septic shock. What is septic shock? So with septic shock, it's the most common type of circulatory shock. It results from a systemic infection. Signs and symptoms of this include warm, dry skin, bounding pulse, and tachypnea. And the last type of shock is obstructive. It's an indirect pump failure that decreases cardiac function by a non-cardiac factor, like a cardiac tamponade or pulmonary embolism. So it's obstructive. The types of shock, I'll go this again. The types of shock include cardiogenic, hypovolemic, distributive, as well as obstructive. Signs and symptoms of decreased tissue perfusion include tachycardia with hypertension, tachypnea, oliguria, cold, moist skin in neuro and septic. Why? Because an inflammatory response is kicking in with that. We have color will be ashen. We'll have change in our color and pallor. This patient will be in metabolic acidosis state and will have a decreased level of consciousness. What are our interventions with a patient with shock? So we'll position this client in a modified transbag position. We'll secure a large bore IV between 16 to 18 gauge. We need to flush this patient. We need to increase the fluid. Fluid administration will be offered at 30 cc per kilogram per hour. And we always administer oxygen because we don't want this patient to be working so hard. We'll also record vital signs every 5 minutes. We'll promote rest and decrease movement. We don't want the patient to be working so hard, and we'll monitor our urine output. So I said we need to give this patient fluid. So the updated treatment for patient with shock, we normally give them a D5 with blood products or just blood products first. And blood products could be administered with either normal saline or lactate ringers. Blood products are normally used to treat hypovolemic shock. You could also hang coagulating factors like plasma or platelet agents for this patient. So let's go to the treatments. With hypovolemic shock, we need to replace that volume and administer oxygen. So that's when we'll be hanging this blood products or giving this patient normosaline. Cardiogenic shock, we need to increase contractility and reduce afterload. What is a good med for this? Digoxin, right? Digoxin has an isotropic and chronotropic effect, right? Septic shock, IV fluids. We need to flush this patient. We need to get rid of this sepsis in the system. We'll give them vasopressins as well as antibiotics like dopamine. Anaphylactic shock, epinephrine or Benadryl. Neurogenic shock, we treat it cause, we treat the cause, right, with a neurogenic. Remember, if it's caused by a spinal issue, we'll stabilize the spine. If it's a medication, we'll stop that medication. Or if the patient is having an hypoglycemic event, we'll bring the blood sugar up. Renal is the key indicator or the best indicator of shock treatment is effective. And with this, we need at least a 30 ml per hour minimum urine output. So when you're treating a patient of shock, we actually need to know that our renal function is working. So we'll do those blood panels to actually know that our renal is okay. With all other types of shock, circulation is an issue, but with anaphylaxis, airway is always compromised. And epinephrine is our first treatment, while others require fluid replacement therapy first. This is something you need to remember. Shock. There are various types of shock. All the rest, apart from anaphylactic shock, we have circulatory issues. But with anaphylactic shock, we are having an airway compromise. Remember, A, B, C. Airway comes first. With a cardiac tamponade, this is where, because I told you cardiac tamponade can be a cause of shock, right? Cardiac tamponade is when the fluid is surrounding the heart in the pericardial sac. And when there's fluid there, it's causing that pressure, so the heart is not contracting well, obstruction. And with pulmonary embolism, we always treat this patient with oxygen fast. So, how do we denote that this patient is having a fat emboli? Because embolism could be a fat emboli or a blood clot. So this patient will have peritobial petechiae, which are red dots or red dashes. So with peritobial issues, right, peritobial edema and petechiae, they are actually indication of fat embolism. Let's talk about valvular disorders. And with valvular disorders, it is a result of narrowing of the valve that prevents or impairs blood flow or stenosis, or impaired closure that causes backward leakage of fluid or regurgitation. It may affect either the mitral, aortic, or tricuspid valve. So this is an issue with valves. Our left side valves are aortic and mitral valve. Our right side valve are tricuspid and pulmonic valves. So you know if it's affecting the left side of the heart or the right side of the heart. Some contributing factors or causes for this is a history of endocarditis. We'll talk more about endocarditis, right? And as well as rheumatoid fever. Some signs and symptoms of this include with red-sided heart failure, because this will lead to left-sided heart failure. So with left-sided heart failure, we'll have mitral stenosis, mitral regurgitation, and tricuspid stenosis. With the right side, we'll have aortic stenosis, aortic regurgitation. We'll also have some murmurs you could hear, and we'll also definitely have some cardiac output issues, decreased cardiac output issues, because remember, the valves are not closing well, so we are having this blood flow, so the output is not that much. So intervention. So with management for this, it's similar to heart failure. So with respiratory, we always auscultate our lungs to make sure that our lung fields are not filling with fluids. We might hear crackles or wheezing. We always place them on oxygen therapy. Higher phyllos position, open that airway, helps with breathing. Fluid volume will decrease fluid. We'll place them on fluid restrictions, right? Low sodium between 2,000 to 3,000 milligrams per day. Where? Because wherever sodium goes, water follows. We'll report any weight increases of either 2 to 3 pounds per day or 5 pounds per week. And with pharmacokinetics therapy, this patient can be placed on S inhibitors, ARBs, nitrates, beta blockers, calcium, all the cardiac medication, diuretics, digitalis, as well as dubetamin. For valvular plasty, it's a procedure. The procedure care is similar to PCI, right? Remember when we were doing the PCI, coronary intervention? So it's a minimal invasive procedure used to open up the clogged coronary arteries that delivers oxygen to the lungs. Like we go open it up. So we monitor for bleeding, respiration, if somebody is not having a hemorrhage, right? We watch for signs and symptoms of systemic embolism. And with systemic embolism, signs and symptoms include cold, lack of pulse, of movement, tingling, numbness, pain, muscle spasm, as well as pale skin and weakness. This will be an indicative that it's been dislodged from the valve. Because if we have this valve, we could end up with an embolism. Also, we could do a valve replacement. We can place in a mechanical valve, which will require a lifetime anticoagulant therapy using warfarin. And remember, we have to maintain the INR for warfarin between 2 to 3. That is the therapeutic level. We could have a biogenic valve replacement and will only require prophylactic anticoagulants for 3 months with biogenic, and with antibiotics prior to procedure. When somebody has this valvular replacement, we always give this patient prophylactic ABTs prior to any invasion procedures or tests, including dental procedures or even to prevent any endocarditis. These are our patients. You ask them if you have any implants, right? Patient with any implants, valvular issues, stents, or whatever, all those prosthetics, they do require prophylactic antibiotic prior to surgery. Thank you for watching. Please like, share, and subscribe to my channel. See you on the next one. Bye.